Hey, good evening, everyone. I am going to be joined by Samantha Knight, who is embryologist at Harley Street Fertility Clinic. So tonight we're going to talk about embryos, everything about embryos, the 5 key things to know, which is super important. I know that from when I was having IVF, and it's obviously fertility week this week, so use her to find out more. Here we go, there she is. And we'll also talk a little bit about too. So she's just joining now. If you've got any questions as we're live, please do ask. That's what we're here for. And hello, good evening.
Good evening.
How are you? You still in the lab?
No, I'm in an office
Oh,
at home, so that's okay.
you're
It's very white and
joining.
clinical. I do apologise.
No problem at all. Thank you so much for joining tonight. Of course, it is Fertility Week, and I've just done a little recap on what we're going to be covering but for people who are joining, we're going to be talking about the 5 sort of considerations around embryos, which obviously you can tell us more about, and also answering people's questions as we go through. So should we start by talking about a very common question around day 3 versus day 5 blastocysts?
Yeah, we can do. Okay, so day 3 versus day 5, there are different schools of thought, but day 5 embryos, so blastocyst embryos, have a higher chance of implantation and achieving a pregnancy than day 3 embryos. It all depends on embryo numbers that people get. Um, most clinics would have a criteria to have a certain number of day 3 embryos at a certain grade and quality, so having the right cell number and the right grade on day 3, having at least probably 3 of those as an indicator to put somebody to day 5 to blastocysts.
Okay. And
Okay.
people focus, of course, I know I did personally, on really wanting those embryos to develop into blastocysts. So should people be discouraged if the clinic says, let's do a transfer at day 3?
I think most transfers, most clinics would probably say to go to day 5, even if it was slightly lower of embryos, because um, embryos self-select from day 3 to day 5, so you get the strongest embryos and those that will achieve a pregnancy on day 5 compared to day 3. So the success rates of implantation are higher on day 5 than they are on day 3.
Okay.
So I would say most clinics in the UK now probably go towards day 5 embryos rather than day 3 embryos.
Um, Samantha, I'm having a few issues hearing you. You're breaking up a bit. Can I ask people watching, is the quality bad on Sam's side or my side? Because I'm not too sure whether it's my internet or your internet. So I just want to get that sorted before we carry on, because it's a very interesting topic. Would someone mind just commenting and letting me know? That would be really useful. Um, do you have signal where you are?
I have no, actually I'm on a mobile data, so I'm not using my internet because my
Sam.
internet is really slow.
Okay.
So
Okay. So we are having problems hearing you and seeing you. Are you able to move somewhere? Oh, you can hear. Okay. All right. We can't
yeah.
see you, but we can hear you. It's just a bit blurred. Um, okay. So day 3 versus day 5. And what about people who don't make it to day 5?
So people that don't make it to day 5, so you can put embryos back on day 3, but sometimes you're making a blind selection as to which embryos to put back, because just because an embryo looks good on day 3 and it says an 8 cell and a top grade may not necessarily be um, the one that is going to make it to a blastocyst and achieve a pregnancy. So
Mm-hmm.
it's very hard to make that decision on which ones to put back. If you don't make it to the blastocyst stage, there's a school of thought that those embryos probably weren't going to achieve a pregnancy anyway. So it's a hard decision to make. It's a decision that most people have to make with their clinician and with the guidance of their embryology team. And sometimes it's down to personal preference. But as I said, I think most clinics would go for the blastocyst transfer over a day 3.
And that was the next question, actually, because I've always wondered this myself. So when you get the call to say what's happening with the embryos as a patient,
Yeah.
is that normally the specialists call, or is that the embryologist or team?
Usually it's the embryologist team that call, but usually they've discussed your results prior to calling with the clinician that's supervising your care.
Sorry,
Okay,
sorry.
so
Who makes that call? Who makes that judgment about the transfer?
oh, about the transfer,
As if
the
when
transfer would
it
be
happen.
so the judgment to be made about when the transfer is going to happen is usually done by the clinician
Hmm.
and the patient, as with along with the embryologist. So it's their choice or the patient's choice as to what they would like to do. Um, the clinician and the embryologist can give advice, but it's down to the patient at the end of the day to choose when they want to put that embryo back. But it's about making an informed choice, isn't it, really, Eloise?
And someone's just asked a question. Is it better to do a fresh or a frozen transfer if you have no issues, just with preference?
Okay, that's a really good question,
Hmm.
actually. Um, it depends on the clinic. We tend to do more frozen embryo transfers at Harley Street Fertility Clinic than fresh transfers, and we have a better success rate with that because sometimes when you do a fresh cycle, the drugs that are used to stimulate follicles can have a detrimental effect on the endometrial lining. So, um, clinics in Japan have gone to doing all frozen transfers for that reason.
Okay.
Um, it depends again on the particular person's case and on the clinician who's helping them with their cycle, really.
Okay, that's really interesting. And also another question that I think you probably hear a lot, which people have asked me to ask about as well, is
Yeah.
grading. What's the importance of grading, and what exactly does it mean in terms of success?
Okay. So there are two different ways that people grade at the cell stage embryo, so up to day 3, and at blastocyst. So obviously, the grading system is for embryos up to day 3, so up to 8 cells, 10 cells. We use, in the UK, we tend to use two numbers, which is the Association of Clinical Embryologists um, way of grading. Okay, and the first number is the symmetry, so the equal size of the cells, and they are stage specific. Okay, and the second number is for the degrees of fragmentation. So obviously, the lowest numbers would be 1, and the top numbers would be 4.
Hmm. Yeah.
Okay, so the higher the grading, the more likely is that that embryo will continue to develop and hopefully achieve a pregnancy. It is stage specific, so at 3 cells and 5 cells and 7 cells, you expect the cell numbers to be not as symmetrical as they would be at 2, 4, and 6 to get a higher grade. Okay, and you can use the grading system and the cell numbers on day 3 to predict how many blastocysts you would expect. So if you had 3 good 6 to 8 cell embryos with grade 3, 3 or above on day 3, you would expect to get 1 or 2 blastocysts. Okay, it might not be those particular embryos, but you can use it as a predictor that you will get some blastocysts.
And someone's
Okay,
just, sorry, were you going to say something else? I was just going to say we've had a question
what
about
does fragmentation
fragmentation.
mean?
Hmm.
Yeah, so fragmentation is where the cells break down and push contents that they don't wish. So it's like housekeeping if you want in an embryo. So if there's something in the cell that it doesn't particularly like, it will push it outside of the cell into a fragment. And all embryos have fragmentation. Obviously, the top grade embryos have less than 10% fragmentation. Okay. Um, and the significance of that is the more fragmentation. So if something was really highly fragmented, probably over 50% fragmented,
Yeah.
you would say that it was probably a poorer quality embryo and it wouldn't necessarily be your first choice to transfer, but it can achieve a pregnancy. Okay,
So have
so
you had embryos surprise you where you've thought on paper they don't look very good and then they do end up being pregnant?
exactly,
And
that
vice
happens quite
versa.
frequently.
Hmm.
Yes, vice versa. So you could have a really good graded embryo, which looks perfectly textbook normal down a microscope. And it could be, for example, it doesn't go on to achieve a pregnancy. And that could be to do with maybe it's chromosomally abnormal. And you could have an embryo look very good, has a poorer grading system, and that goes on and achieves a pregnancy.
Mm-hmm. Actually, when I had my twins, I was studying the embryo card a lot, as many people do, will resonate with during the 2-week wait. And both of those two embryos looked so different. It was unbelievable, and they both ended up resulting in babies. So it's strange,
Exactly.
isn't
So
it?
it really is. And unfortunately, fertility isn't an exact science.
No.
If it was, it would make everybody's dreams come true really quickly.
Mm,
Um, and that 2-week wait can be really the longest wait ever, to find out whether
absolutely,
somebody's pregnant or not. So
absolutely.
yes. So
And
um,
something that has come up quite a lot today with Fertility Week, people have been talking about men and male fertility. And I wanted to ask you, in terms of embryos and sperm, especially when you're doing ICSI or when it's normal IVF, what about the sperm morphology and motility?
okay, so this is quite interesting. There are some clinics in the UK that don't look at sperm morphology anymore.
Wow, okay.
Okay. So if they, on semen assessment of the semen preparation, if they do an analysis, they would do concentration, they would do motility, but they wouldn't do morphology. We still do morphology. Obviously, morphology when you do IVF or ICSI depends on the percentage. So 4% being normal is the World Health Organization standard, okay, which seems really low, and people are quite shocked at that. So if it was below that, then if there are other parameters that aren't quite within the normal ranges, then they will probably have ICSI. All right. And when we do ICSI, we prepare the sperm in exactly the same way as IVF. And we would then select the sperm down the microscope to use to inject into each egg. All
Mm-hmm.
right. We try to pick the eggs that look the most normal on morphology front. Okay. And then they're the ones that we would use for ICSI. Obviously, with IVF, it's if you want survival of the fittest, so that is the strongest swimming sperm that reaches the egg, that as in nature, and therefore is the one that would achieve fertilization. Okay, so motility is a big part if you're having IVF. Motility isn't such an important factor if you're having ICSI. All right.
And would you mind, just for people who may not know what that means, just explaining what that is?
ICSI, of
Oh,
course.
no,
So
sorry, the sperm
uh,
morphology and ICSI.
morphology. Okay, so morphology is the shape of the sperm. So whether a sperm has a normal shaped head, a normal length tail, and a normal mid piece, which is the bit between the head and the tail. All right, because some sperm may have two heads or two tails, or may have a thick under mid piece, or may have vacuoles in the head, or lots of things can be not textbook how you would imagine a sperm to look.
So when
Okay,
you're
so it's
doing
how it's shaped.
ICSI, you can
Yeah.
obviously discard sperm which may look like they have an issue.
So you would, when you were doing ICSI, you would look for the most normal looking sperm. You can also do something called IMSI, which means you concentrate on the morphology more. So you use a higher objective, and then you can see more detail and you can look for vacuoles and their position in the head, which can maybe increase fertilization in people that have had low fertilization in the past with IVF or with ICSI. Um, and what that tends to mean is that when you may use that as a tool to get better quality embryos and maybe decrease the chance of somebody miscarrying
Okay,
due to a sperm factor.
that's
Okay,
fascinating. Thank you.
that's all right.
Emmy has asked, in your opinion, what are the chances of a natural pregnancy with sperm morphology of 1% if motility or the count is good?
It's really difficult to say,
Yeah.
and never say never,
Yeah.
because it can happen. 1% is a really low motility, so I would say it's a particularly low chance of achieving a pregnancy. probably, if it's less than 1%, um, on morphology, it's really hard to put a percentage on it, but we would expect it to be a low chance. Doesn't mean that it's not going to happen though.
And what about the options for that?
So if you've got a morphology of 1%, most clinics would do ICSI. So they would do the procedure where you pick up a sperm and individually inject one sperm into each egg.
Yeah. Okay, great.
Okay.
And any more questions people have, just shoot them over. And then the next thing we're going to talk about, thinking about embryos, is PGS or PGT, and how that affects success rates.
Okay. So PGTA, okay, or PGS as it used to be called, is pre-implantation genetic testing. Okay, and it looks for losses and gains on every chromosome. So we're looking for chromosomally normal embryos. Okay, in ladies over 40 who are having IVF, the number of abnormal embryos is usually around 80 to 85%. So
That's
in that
huge.
age, it is huge. It's a lot
Yeah,
higher than you would expect.
yeah.
So in that age group, by identifying the normal percentage of embryos and then putting them back in a subsequent frozen embryo transfer cycle increases their chance significantly. Okay. So in that age group, it probably increases their chance to about 50% if we can identify a normal embryo. Obviously, it may be some time before you can find a normal embryo, and it depends again on the number of embryos that are tested.
Mm-hmm.
Okay. With younger ladies, so ladies, shall we say 35 and under, it doesn't necessarily increase your chance of achieving a pregnancy, but it will decrease the number of attempts of transfers to get to achieve that pregnancy because, again, we're putting a normal embryo back and we don't know if we do ordinary IVF without the testing, whether that embryo would be normal. And therefore, it may take you 2 or 3 attempts at a transfer to achieve a pregnancy. But if we put back a chromosomally normal one, your chance of achieving a pregnancy is about 65%.
And are there any negatives about doing it? Is it purely cost, or is it a concern that it might damage the embryo?
It's, I, I think it's quite costly. I, as to being, um, if there are any risks about damaging the embryo. So obviously, most clinics and embryologists, if they think they're going to really damage the embryo and they don't think it's suitable to do that, will not biopsy the embryo in the first place.
Mm-hmm.
Okay, and the cells that we take from the embryo are cells from the part that form the placenta and the amnion, so not the part that develops into the fetus. So I know people are quite concerned about that, but it's the part that develops into the fetus we do not touch at all.
Mm-hmm.
Okay, and it's just the cells in the trophectoderm reflect what's going on in the inner cell mass, which is the bit that develops into the baby.
And then I guess people must be very disappointed if they've gone through that testing, and it's looked like a good embryo, and then it doesn't result in a pregnancy.
Exactly, and that can happen sometimes. It obviously, if we know it's a normal embryo and we've put it back and it doesn't happen the first time, then hopefully, if they've got other embryos, they can have those back subsequent cycles. Um, and that's the one mystery, really. So if we have something that we know that is normal, and you put it back, and people have quite high expectations of achieving a pregnancy because they know that that's a chromosomally normal embryo, and it doesn't achieve a pregnancy the first time, then they become quite despondent, yes, but sometimes they have a second cycle and then that happens. So just because the embryo is perfect, whether that's looking down a microscope and it looks a really good quality embryo and you know that it's chromosomally normal, does not necessarily mean it will achieve a pregnancy.
Mm-hmm. It's difficult to hear, isn't it?
It is.
Yeah. And actually, the next thing I wanted to ask you about, because thinking of these 5 main categories that we're talking about, or main considerations that do come up a lot, and you probably hear this one a lot as well. And of course, there are so many other factors, but implantation failure and it not working, do you think that the majority of that is down to the quality of the embryo?
Okay, implantation failure. I would say quite a lot of it could probably be due to chromosomal abnormality, but there are other reasons why things do not implant. So it could be down to the quality of the embryo, but there are other things to consider. It could be to do with the timing. So it could be where, for example, somebody's endometrial lining and receptivity is not in time with the standard time for replacing an embryo. All right, so it could be there are lots of tests out there where they now do endometrial biopsies in trial cycles for people that have had repeated implantation failure,
Mm-hmm.
um, giving the same medication as if it was a frozen embryo transfer cycle and finding out what is the most receptive time for that person's endometrium. So it could be that usually if you do a blastocyst transfer, we put them back on day 5, but it could be that people in ours doesn't fall on day 5, but it could have fallen on day 6, for example. And that could have been a reason they've had maybe several implantation failures when we know that their embryos are of a good quality and they have also had PGTA and we know that we're replacing normal embryos.
Mm-hmm. Absolutely. Thank you. That's really insightful. Does anyone have any more questions? If so, please send them over now whilst we've got Sam here. And is there anything else that you wanted to say, Sam, about embryos, or for people who are obviously going through treatment at the moment and conscious of all of this?
Yeah, it's really difficult to go through treatment. I think most professionals know that it can be emotionally quite a traumatic time for patients. Um, and I think if you are finding it difficult to do some treatments, especially when you've had several that have failed, maybe, there are the counselling services and the staff do understand this, that it can be difficult. Um, but we're all there to help. So,
Mm-hmm.
just ask the questions to your embryology team or your clinician. Most people will be willing to spend time with you.
Absolutely. Yeah, I think that's great advice because holistic care is so important, isn't it, on such a
It
disorder?
is. It is. Yeah.
Suzanne's just asked about supplementation to help with egg quality and implantation. But that's, I know we're talking
Not
about
really
embryo.
my
No,
field.
I know.
I know there are lots of things out there, and maybe that's a good question to put forward on another
Absolutely,
Instagram
absolutely.
live if you've
Suzanne,
got a
come and join
clinician.
another one where we've got more specialised um, answers for you. Someone else has just asked the
For
same. So tonight we're
endometriosis,
just
that's not
talking
for
about
me either.
embryos, but it's been very, very insightful. So I'm very grateful for you coming on tonight.
That's all
Hopefully
right.
it's been helpful for people who are watching and watching this back. And we will speak to you soon.
Yeah, thank
Okay.
you.
Thanks everyone for
All right.
joining. Bye-bye.
Thank you.
Bye.
Bye-bye.